Handling of allergen immunotherapy in the COVID-19 pandemic, an ARIA-EARCI statement. A Q&A with Professor Walter Canonica from Milan, Italy, a co-author on the statement paper, and Associate Professor J.Rimmer from Sydney, Australia. The recording of this medical education video was facilitated by the Stallergenes Greer Global and Asia Pacific Medical Affairs Departments.
So I'd like to welcome any participants to this conversation tonight, and particularly I want to thank Professor Walter Canonica from Milan in Italy for making yourself available to talk to us today. We really appreciate it. As you know, the whole world is preoccupied with the COVID-19 pandemic, and for allergists, the practices of social isolation and social distances have posed quite a lot of challenges in the management of allergen immunotherapy. So you and others have been involved in producing an ARIA-EARCI statement, and the title is here in the slide. Walter, can you briefly take us through what the purpose of this position statement has been and how it will help allergists with their practice in the COVID-19 pandemic era?
First of all, thank you very much for the invitation. I'm very pleased to share with you what was the position paper that we wrote. Well, actually, nowadays it's very difficult with the pandemics, and you know that unfortunately Italy is one of the countries where the coronavirus was more tough. To make more acceptable and mainly for informing, I would say, our colleagues and if the case also our patients about what are the procedures to be used during these pandemics. We decided to revise what are the way to act properly. And that's the reason why the European Academy, in conjunction with the ARIA, and I'm pleased to say that I'm working in both of the organizations, actually decided to make these kind of statements for advice to our centers.
So let's go straight into the practical aspects of managing immunotherapy in this era. So what do you recommend to physicians and other people who dispense and give either SCIT or SLIT? How have you managed it within your country, in your allergy practices?
Let me say that first of all, the point is depending on the country. Because in some countries, look, for instance, Italy, the vast majority of patients is treated with sublingual immunotherapy, whereas in some other countries, like Germany, for instance, subcutaneous immunotherapy is the most used route of administration. Nonetheless, in the recommendations that we can see in the next slide, for instance, we consider both routes. And first of all, and I think that this is the major recommendation, immunotherapy shouldn't be interrupted. This, of course, is valid, as you can see in the slides, both for subcutaneous and for sublingual immunotherapy. And of course, we are talking about non-infected people. In the third recommendation, is the added value of sublingual immunotherapy. Let me share with you also an important point. The important point is, and I'm happy that Australia is not affected as we are by COVID, but could you imagine a person that has to go to the hospital for receiving a shot, and for grass immunotherapy, for instance, and having to take the subway, and with the risk of infections that we know is quite high in the public transportations. And that's the reason why in the third bullet point, we suggested that since sublingual immunotherapy can be taken at home, of course, is favorable in this precise moment. Let me tell you also that in some other recommendations, this is exactly the same kind of approach that was used for biologics in severe asthma. There is a forthcoming paper of the World Allergy Organization that is also focusing on this exact point, and also the NICE document that is suggesting, whenever possible, to use an at-home administration. What does it mean in terms of organization? That we have to organize with our pharmacy, for instance, in the hospital, a delivery at home of the patient of these drugs. If we are going ahead with the next bullet point, I think that it's important to stress that both subcutaneous and sublingual immunotherapy can be continued, and the only moment that should be interrupted should be, and then we can discuss why, in persons having the symptoms and the positivity for viruses. Why I'm saying that? Because we do not know if there is any interference. Let me tell you that as far as we know, the viral infections are not interacting in any way with allergen immunotherapy, or the opposite. The allergen immunotherapy is not interacting in any way with the viral infection, but we cannot derive that this is also the case with this SARS-CoV-2. Now, the conclusion or method, the suggestion is to go ahead with the sublingual or subcutaneous immunotherapy, just to interrupt as a precaution during the symptomatic treatment period of the disease. And I think that this is really very, very important. As far as the allergy center, how do we need to set up the allergy clinic? Well, there is a sort of revolution. The sort of revolution that we did, and we did in a very, very short time, is to use much more digital medicine than we did in the past. And this is, of course, very, very important, because we are in contact with the patients in a virtual way. Let me tell you that this is an old story. Everybody was talking about digital medicine, but digital medicine was something more theoretical than real. Nowadays, it is something that it became real in a while. And this is very important. But if I may, this is also true for the medical university. I mean, we always had our students in front of us, and we gave lessons to them. Nowadays, we are using streaming every day for the lessons. So it's a changing world, and the scenario is definitely different. As I already mentioned, going back to the point of the allergy clinic, it's very, very important in the organization. Today, what is the pharmacy for home delivery of the products? On the other side, we just discussed in our university hospital, it's gonna be very important to respect the distances for the outpatients. And so the organization in these terms about the appointments that should be respected very, very properly. Otherwise, you are going to have a crowd outside waiting. And this is another risk for dissemination of the virus. I know that this is a very practical aspect that is not really dependent of the topic today, the allergy, but in terms of organization of an outpatients clinic, I think that this is something that should be in mind. The last point, I think that we already covered. We do not have yet informations. Probably we will get monitoring what's the situation that is currently going with this pandemic.
So thank you, Walter, for that comprehensive answer. Yes, I mean, it's been a steep learning curve for Australia, both in terms of digital medicine, as you mentioned, and also social distancing and how to interface that with the practice of medicine. You mentioned at the start of your answer that some countries do more SCIT than SLIT. Do you know whether your colleagues in those countries have tended to switch from SCIT to SLIT, given that there is the ability to self-administer SLIT?
No, Jen, I'm sorry, I cannot give you any information about that because the data were not yet collected. And as far as I know, there is no structured study up to now about the switch from one route to the other route. This is something that, in my mind, should be done because we should be prepared.
I mean, do you think it should influence allergy practice going forward?
In my mind, frankly speaking, I would say I would like, because of two reasons. So first of all, there was a paper that was just came out very recently in the Clinical and Translational Allergy about the quality of life of the patient and also the effectiveness of allergen immunotherapy, showing again that there is no difference between sublingual and injective and subcutaneous immunotherapy. So, I mean, we should consider two different tools. And once more, in terms of personalized medicine, it depends also what is the participatory medicine. What I mean is you have really to deal with the patient and to think about also what's the preference of the patients in terms of choosing the route of allergen immunotherapy. But I mean, we should properly deal with a protocol that is able to support us whenever a switch from one route to the other route is needed.
So, I mean, the other area that we haven't yet covered are patients who are infected. And as you've mentioned, Italy has a lot more experience than Australia in that regard. I mean, I think we've been extremely fortunate, and I think Italy has been one of the hardest hit countries. So you would have a lot more experience about this than we do. So in general terms, in somebody who has a febrile illness, you would discontinue immunotherapy during that period of time. So what has been the scenario for COVID infected patients, and the ones who obviously get into hospital are often there for quite a long period of time?
If I may, I should give you a premise. And the premise is, if you look at the data from China, very few people with allergy were affected by the virus. We are currently running a study in our registry of severe asthma. Probably you heard about SANI, that is Severe Asthma Network Italy. We are currently having more than 1,200 patients with severe asthma. And I can tell you that we found out that just 20 of them had COVID. In addition, there are also, there is a very nice paper in press, or just on, not yet printed, but in Galley Proof. You can find it on PubMed, showing that IL-13 is decreasing ACE, which means the receptor for coronavirus. But what is even more amazing is that if you are challenging a patient with the allergen, even at bronchial and nasal level, you can get a decrease induced by the allergen of the receptor for coronavirus. So this is just to say that probably allergy means a sort of, I wouldn't say defense against, but at least our patients are less susceptible to the infection. And this is, go ahead. Sorry.
So that seems to be quite different to the COPD data, doesn't
Absolutely.
it? Yeah.
Absolutely. I can't agree more.
Yeah.
It's,
so that's
really,
yeah, that's good news.
even in severe asthma patients.
Yeah. So, I mean, in your part of the world, you're coming into spring. Do you think that this poses additional challenges for the management of allergic rhinitis patients?
In terms of dealing with them, probably yes, because of the lockdown. In other words, once more, I should stress the new reality of the digital medicine. But in addition, I have to say that nowadays the media are working, I would say, properly in referring to the centers and to inform the patients about how to deal. If the symptoms are refer to the allergy centers, if I mean you are suspecting that the symptoms are due to SARS, I mean you have to inform your doctor, you know.
Yes, I mean symptoms such as sneezing and coughing are now very socially frowned upon, and coming into spring with symptoms of allergic rhinitis, I would imagine that will be difficult for patients and perhaps is an additional factor to try and control symptoms optimally.
Well, let me say, in these slides we summarize, the paper is currently submitted, and it's a way to deal with the different symptoms. On the left, due to allergy; on the right, due to the viral infection. Let me say that there is one point that is very, very important, and the difference is fever. Fever, shortness of breath, and fatigue. And these are not in the allergy field, never. You will never have fever because of rhinitis, not even for asthma. But if you have fever, I mean, you have to call your primary care physician first, and then depending on the protocols in the different countries, you have to refer to a center for SARS.
Mm-hmm.
The second point, if I may,
Mm-hmm.
and is a symptom that is very, very proper of SARS, is the loss of smell, and the loss of taste. We as allergists, we can usually see these kind of symptoms for nasal polyposis.
Yeah. But
a nasal polyposis, this kind of loss of smell is, let's say, is coming in months. Here is a very sudden symptoms. So whenever the symptoms are loss of smell plus whatever you wish, conjunctivitis, rhinitis, but if you have a loss of smell, fever, and dyspnea, shortness of breath, definitely is not an allergy.
And in your experience, does the loss of smell and taste, is that easily reversible, or is it permanent?
Is it reversible, but not in a short time? Even people that is recovering from SARS needs weeks to recover.
Yeah.
I mean, it's not something that you can recover immediately. Let's say, for instance, in our experience, we treated the nasal polyposis with monoclonal antibodies, with dupilumab, for instance, and we got a response also on loss of smell in a week. This is not the case with SARS.
So I think we're sort of coming towards the end of our time. So Walter, are there any additional points that you would like to make in relation to immunotherapy in this era?
Let's say that my suggestion is to consider, first of all, to keep going with the treatment, which is absolutely the way to protect our patients. The second point, as we stated, is that we need to restructure the allergy clinic compared to the past. And as far as immunotherapy, of course, to consider properly what are the advantages of sublingual immunotherapy in these awful situations. But as for biologics for severe asthma, we always have to keep in mind what is the best for our patients.
Yeah. Well, thank you for that. And thanks very much for taking part in this digital discussion. I'm certainly looking forward in the future to face-to-face meetings. I hope that they do come back, but as you know, most of them have been cancelled for the short foreseeable future. Thank you very much.
Thank you.